Thank you, Dr. Cyrus D'Souza. Thank you for being here with us. Dr. D'Souza is a professor and chief of the Division of Diabetes, Endocrine, and Metabolism at the Department of Internal Medicine at the University of Nebraska Medical Center. He's also the director of Diabetes and Obesity Program for the VA Nebraska Western Iowa Healthcare System. He's a board certified clinical endocrinologist with research interests related to cardiovascular disease and insulin resistance and diabetes and improving outcomes in diabetes and obesity. Dr. D'Souza received his medical degree from St. John's Medical College, Bangalore. He completed a rotating internship at St. John's Senior House Residency at Nair Hospital. Fantastic. I'm meeting a fellow Nairite. We are celebrating 100 years this year. And then went on to Bronx, New York Hospital and a fellowship in the Division of Endocrinology at Tulane University, New Orleans, Louisiana. He has authored and co-authored several articles in major journals and present at national and international meetings. He has been a PI for several grants, including a VA Merit Review grant looking at glycemic control and other basic cardiology-related grants. He's a site PI and an ancillary study and steering committee member for a large NIH study. The GRADE, which is a national study comparing current medication and protocols. We just had Dr. Makkar speak on it. He's also the chair of the ancillary studies committee in the large NIH trial using vitamin D to prevent type 2 diabetes in people with prediabetes. Are honored to have you here. Over to you, Dr. Cyrus D'Souza.
Thank you. Let me share my screen here. Okay, I'm hoping everybody can see my screen there.
Yeah.
So today we are going to actually discuss, these are my disclosures for everybody. And today our objectives are actually a focus on management of dyslipidemia in diabetes. So I think most of us are very familiar with general management of dyslipidemia in the general population. So we're going to first review some pathophysiology of what is slightly different in patients with diabetes in terms of lipids versus general patients, and the role of cardiovascular disease in diabetes in terms of lipids. And then we're going to go over some management guidelines for diabetes dyslipidemia. I'm focusing on the guidelines by American Diabetes Association. I will mention slight differences that may occur from AHA or other organizations. And then the more major part of the talk will be actually to show you some trials in terms of how they affect diabetes patients in different classes of the lipid drugs that are there. So you've probably seen a lot of trials in general with general information for everybody, but I'm going to focus in on those trials that actually have diabetes data. And so they may be a little different than the general population. So as we know, I start with the earliest slide that you can find because this has held through all of these years. But in this Birmingham Heart study, you can see that any cardiovascular event or that you take, either males or females, you have an increased risk for these events in patients with diabetes. And we also know that with each addition of a risk factor, we usually will get an exponential increase in cardiovascular risk in type 2 diabetes versus people who do not have diabetes. So this is showing you 1, 2, 3, and all 3 risk factors where cholesterol is one of those major risk factors. And you can see that the people in diabetes have a much higher risk. A little bit about the pathophysiology in diabetes that is not always true with the general population. So as you know, when we eat, we have chylomicrons, which are absorbed from the intestine and go to the liver. And at the liver, which is the main producer of all types of lipids, including LDL, VLDL, HDL, etc. What happens in diabetes is there's an increased production of VLDL, which we measure as triglyceride. Because there's an increased production of VLDL in the system, there is an excess of triglyceride. Now, usually the triglyceride is removed by tissues with the help of an enzyme called lipoprotein lipase, which all tissues have. Now, in diabetes, this enzyme is usually, especially in type 2 diabetes, resistant to the actions of insulin. So the activity level is low, and therefore you have an increased production and a decreased removal, and therefore high triglyceride. On the flip side, the HDL that's produced by the liver is, as we know, a kind of a scavenger lipid. And these scavenger lipids bring back the remnants of lipids to the liver. And this is the reason why HDL is low in patients with diabetes. So the hallmark of insulin resistance is actually high triglyceride and a low HDL, even in the absence of any dysglycemia. So it is an early marker. Hepatic lipase is also increased, which further stimulates triglyceride production. Now to come to LDL. The LDL levels are not necessarily different, but the quality is different. So they are small, they're dense, they're easily oxidized LDL molecules, and therefore they are easily cause endothelial injury to the vasculature, which is why patients with diabetes have an increased risk of cardiovascular disease. So with that brief introduction on pathophysiology, I'm going to go into the management of patients with diabetes and dyslipidemia. And these are some of the ADA guidelines. So we start with primary prevention first. So for patients 40 to 75, and we'll deal with 75 a little later because the data is a little different there. So patients between 40 and 75 without any cardiovascular disease, we need to use a moderate intensity statin to, in addition to lifestyle therapy. Now, all of these recommendations are obviously based on the ASCVD risk score, which you might know as a calculator. And having diabetes increases the risk anyway. So by how much is depending on whether you have cardiovascular disease or not, and what is your age. For patients with diabetes that are 20 to 39, and they have cardiovascular risk factors additionally, it may be reasonable to start a statin. There is no plus or minus evidence, especially in type 1 diabetes. So that would be a clinical decision that you would make. And in patients with diabetes at higher risk, especially those that do have multiple cardiovascular risk factors, or whose age is greater than 50 to 75, it is definitely reasonable to use a high-intensity statin therapy. Then coming to the 10-year ASCVD risk score itself, if you have a risk score that calculates out to 20% or higher, it may be reasonable to add something else like Zetia or ezetimibe to maximally tolerated statin to reduce LDL cholesterol levels by 50% or more. So these are some of the guidelines for primary prevention. For secondary prevention, for patients of all ages with diabetes and presence of cardiovascular events already, a high-intensity statin is definitely added to lifestyle therapy. And for patients with diabetes and cardiovascular disease that are even higher risk, and if their LDL is above 70, on a maximally tolerated dose of statin, then you should consider either Zetia or a PCSK9 drug. As you know, that ezetimibe is probably more cost-effective than the PCSK9 inhibitors. For patients who do not tolerate the moderate or high-intensity statin, the other means should be used. And this is just an opinion because there are really not many trials looking at that specific population, which I feel is a problem because there are a significant number of people who are statin intolerant, truly, or are in very tiny doses of statin, which we don't very much know the effect on the cardiovascular risk profile. So now I'm going to show you a couple of trials on LDL. I start with, and this is always, remember this lecture is focused on diabetes and what is the effects on diabetes. So I always like to start with the first significant trial, which is, many, many years ago in 1997, it was published, but holds true till today. So you can see that in this trial, patients with diabetes had more of an effect in terms of reducing risk of major coronary vascular events than people who did not have diabetes. Now, in this slide, I've tried to summarize all the important trials that have been held. Some of them have shown diabetes patients separately, and some not. Most of them at least have shown equivalent benefit for diabetes patients versus non-diabetes patients, while some trials show an extra benefit, like the FOREST trial and the CARDS trial. So nevertheless, the uniform message is that it works for patients with diabetes. Here is a list of different intensity statins in their various doses. So most statins can be given at moderate or high intensity. Atorvastatin and rosuvastatin are the two main high intensity statins at their 40, 80, and 40 doses, while the other statins are at lower doses. Certain slightly weaker statins, such as fluvastatin at 80 milligrams at the highest dose, is considered a moderate intensity statin and may be tried if a high intensity statin is not tolerated. Okay, so here I summarize the different available agents that have effects on lipids. So we already know that statins have a reduction in LDL up to 60%, depending on which statin and what strength. The main side effects, as we know them, are myalgia and muscle related. And rarely you may have rhabdomyolysis. Liver functions may also be affected. And there are many strategies to try and modify those side effects, maybe try different statins at lower doses. Some people have suggested vitamin D replacement and coenzyme Q10, but those are not proven by randomized controlled trials. There are the cholesterol absorption inhibitors like ezetimibe, which lower LDL by about 20%. They have lower side effect profiles than statins. PCSK9 inhibitors, they lower LDL powerfully, 50 to 70%. The injections, so some patients might not like that. And you may develop side reactions to injections. Niacin was a very promising drug until the trials were held, and I will show you that. Used to lower non-HDL cholesterol 20 to 50%, which was thought really good. But it has significant side effects of flushing and hyperglycemia, which causes an A1C increase on an average of 0.7. So really not probably that great for diabetes patients. We have fibrates like gemfibrozin and fenofibrate, which have a modest effect on LDL and a larger effect on decrease in triglycerides, have similar side effects such as statins, and should not generally be combined with statins unless really needed. And even if so, should not exceed the 50% dose. And then we have omega-3 fatty acids that usually deal with the triglyceride component of dyslipidemia. And they also have problems, especially in patients with coagulation, anticoagulants. They can cause increased bleeding actually. And in patients on antiarrhythmic, they can actually displace that antiarrhythmic and make that worse. So they're not as benign as we think they are usually. All right, so what I want to do is actually talk about the addition of, or the benefit of ezetimibe when added to a statin in terms of diabetes and non-diabetes. So in this analysis, you can see the primary endpoint. There was more of a benefit in diabetes patients than in non. In fact, if in this trial, if you had taken out the non-diabetes patients, the trial may not have been shown any significant improvement in terms of cardiovascular risk reduction. So if you take the primary endpoint or any of the secondary endpoints or any of the tertiary endpoints, you see that diabetes patients seem to have more protection in this study than non-diabetes. And that's why the guideline has suggested that people with diabetes with extra cardiovascular, multiple cardiovascular risk factors, maybe the addition of ezetimibe to a statin might be truly beneficial to them over and above non-diabetes patients. In this figure, I would like you to concentrate, this is the same trial. I would like you to concentrate on the red and yellow lines, which is diabetes patients. You can see that patients treated with Zetia and a statin, in this case simvastatin, had a marked improvement, about 15% reduction, risk reduction. And versus the non-diabetes population, which is the blue and green, which really had no difference. So you can see that really the difference lies in the diabetes patients. And this is a 5-point MACE, which I've listed. And this is for cardiovascular safety and efficacy of PCSK9. And you can also see here, in terms of cumulative difference in patients with diabetes in the four-year trial. So this is specifically diabetes. And you can see that there is a definitive benefit to diabetes patients in terms of both the 5-point MACE and the cumulative cardiovascular death rate. So again, to emphasize that it seems to be that diabetes patients have a slightly better outcome than non-diabetes patients. And if you look at, and that was in the 4-year trial. However, if you look closely at a meta-analysis of all the trials of PCSK9, it does show that there may not be a significant difference between diabetes versus non-diabetes, but do remember that these are all trials that add a PCSK9 on top of a maximally tolerated statin. So we don't really have a trial that looks at diabetes patients without maximally tolerated statins. And I think that would be a very useful trial if one could be done. Nevertheless, you still have benefit as the total, you can see the bottom line there, you still have about a 22% decrease in the composite endpoints. So it's still pretty decent. There's a new drug called Bempidoric acid, and I'm not sure how many of you are familiar, but it acts in the same pathway as the cholesterol manufacturing pathway that statins work on. This is an inhibited enzyme earlier in the cholesterol pathway. But you can see with different trials that they've done that are listed over here from Harmony, Tranquility, Serenity, and Wisdom, that averagely there's about somewhere between 15 and 20% reduction in LDL. And some of these trials are over and above a maximally tolerated statin. And then Tranquility was in addition to with Zetia, so it shows the maximum effect that can have. So I think this is a useful tool in patients who may not tolerate maximal statins. Now, does this affect cardiovascular disease? We don't know really because we do not have a randomized controlled trial. It is ongoing as we speak. But we do have a meta-analysis of the data, and it seems to show at least some signal of benefit. That means about a 17% benefit. We shall await the results of the cardiovascular outcome trials here. So moving on to lipid fractions, especially triglyceride levels. So for patients with triglyceride greater than 500, the main risk is pancreatitis, and we would consider medical therapy. In patients with 175 to 499, we should address secondary factors first, such as diabetes itself and hypothyroidism, nephrotic syndrome, and then consider medications. In patients with cardiovascular disease or atherosclerotic disease, on a statin, but they have triglycerides 135 to 500, we should treat that, and the addition of icosapent ethyl, which is Vascepa, can also be considered in this particular group, and I'll show you some data. And then we do not really recommend statin plus fibrate. There's no additional cardiovascular benefit. I will show you a couple of slides on that. And niacin, unfortunately, has not been very great in terms of addition to a statin and lowering cardiovascular risk, in spite of lowering non-HDL cholesterol. So you can see the ACCORD trial, which is a lipid we had a lipid portion and a diabetes portion. And you can see, unfortunately, adding fenofibrate to a statin does not lower either total mortality or a 3-point MACE between placebo. And these are all diabetes patients. So it does. That's why the recommendation says that perhaps adding fenofibrate to a statin is not beneficial for cardiovascular outcome. It may be beneficial if you want to reduce triglycerides greater than 500 for pancreatitis. And caution must be used because of interactions between statins and fibrates. So this is the trial which unfortunately showed us that niacin is not as great a drug as some thought. And this is called AIM-HIGH trial. And unfortunately, when you added niacin to a statin, there was actually no difference in any cardiovascular outcomes. Plus, people had a lot of side effects, and there was a high dropout rate from the use of the statin, so the use of the niacin. And therefore, niacin is not considered. In addition, in diabetes patients, it caused hypoglycemia and increased the A1C averagely by about 0.7, which is almost equivalent to adding allogliptin as a medication. So not good. So last portion, do we treat patients who are older than 75? So in adults with diabetes, age 75, those who are already on a statin from before, they're fine, you can continue that. In adults that are diagnosed with diabetes after 75, it may also be reasonable with discussion with the patient. There's not enough data in this set. There's a new study called the preventable study, which is now being conducted in this very population. And we shall know maybe 5 years from now whether what is the exact benefit. And statin therapy is not indicated in pregnancy. Now, I'll show you this particular slide about the age and relationship to statin therapy. So on the left, no diabetes. On the right column, there's type 2 diabetes. I will focus on the right side. As you can see, there seems to be a benefit in patients with diabetes up to about the age of somewhere between 85 and 90. That means the blue line is below the black line, which means the risk is lower than 1. But as you age above 85, 90, it seems like it may actually be harmful in other ways, like mental and other stuff. So again, this is a modeling study, so we don't truly know what to think, but certainly there is some signals that it may not be good to start patients like if they're over 87 or 90. We will know this for sure when the preventable study results are published. So in the last few minutes, I want to just summarize. So take-home points, statins at high intensity are very effective for both primary and secondary prevention in diabetes. Ezetimibe statin combination may be more effective for secondary cardiovascular disease prevention in diabetes than without diabetes. Niacin is not useful in combination with statins for CVD prevention in diabetes and has tolerability issues. Fibrates may not give added risk reduction when combined with statins in diabetes, and they have safety issues. PCSK9 inhibitors do give lower cardiovascular risk in both patients with and without diabetes to a modest extent when combined with a statin. So with those comments, I shall end my lecture. Thank you.
Thank you very much, Dr. D'Souza. And can you please stop sharing so that I would request Dr. Guillermo also to come on so that we can have a combined question and answer. Thank you very much, Dr. Guillermo. And I'll open up the session for question and answers. And I'll yeah, please go ahead, Raju. You want to ask something? Please go ahead.
Thank you so much, Sanjay. I'm sorry I was butting in while you were talking. Dr. Ompires, my first question is to you, is that some of the pickup of GLP-1 evidence-based approach in patients with established cardiovascular disease has not picked up in India. Probably price and injectable is probably the reason for it. But do you think that with the oral GLP-1, it will pick up, one? And two, do you think that we can extrapolate the advantage of sustained 6 to Pioneer 6?
Yeah. So this is amazing, your questions and the way that is real world. And there is a paper in the New England Journal of Medicine published in June 10th that speaks about the trend utilization of drugs in the United States up to 2018. And about 60% or 65% are using metformin. Sulfonylurea is about 30%, insulin about 25%. And when you have combined SGLT2s and GLP-1 is 7%. So, and you saw the data that was presented earlier on today, that even in patients who have cardiovascular disease, the utilization of GLP-1 and SGLT2 is less than 20%. So we have a diabetes platform at Emory, and looking at medication utilization from GLP-1 is used in less than 15% of the patients. So the question is why? So in talking to our primary care that we meet every month, is that it's cost, and most of them require prior approval. And that means that somebody in the office has to call the insurance company and beg to be able to use those medicines. And primary care are so busy that if you have to call the insurance company, they just don't do it. They just don't do it. So we just got approval from Medicaid to use liraglutide, and maybe that's going to increase utilization of these agents. So the data is very clear. I don't know if it just take a generation for get included in primary care, or 5 years, maybe not enough to have this data. The SGLT2s are used a little more, but again, most people who would benefit, and I think it's the matter of cost, or a matter that sometimes you have to get pre-approval to use these medicines. So something needs to be done. And I think the main reason is cost. If all the medication costs $1, would you ever use sulfonylureas before SGLT1 or SGLT2? The answer will never be there. That's right. Why does sulfonylurea still 30% utilization in the United States is not clear to me. They're cheap, but that's it.
So if you was to, considering now the oral sema is going to be available in majority part of the world, do you think that if cost is to be kept aside for people who can afford it, do you think our initial therapy should start early combination of, let's say, oral sema with oral SGLT2 inhibitors? And if I may sort of tease Dr. Cyrus's brains also, that start statin early in all our patients with diabetes, and the composite may probably bring the cardiovascular risk or cardiovascular disease down?
Yeah, early combination therapy have been shown to be more durable effects on glycemic control. And if you use this early combination with, with the SGLT2s or GLP-1, may have some cardiovascular and renal protective effects. Now, I'm very careful when I have to start metformin GLP-1 combination because of the GI side effects. And then you don't know which one gave you the nausea and the vomiting, or the nausea or diarrhea. So I very seldom combine these two at the same time. But with respect to metformin SGLT2s, I'll do that all the time. So if I have a patient who have cardiovascular risk factor, hemoglobin A1C is greater than 8.5, 8%, I will start from the beginning with these two agents.
I just want to ask here that what will be the future of DPP4 inhibitor in the era of this oral semaglutide? I mean, that's the most of the oral DPP4 inhibitors, they don't have the CV safety data. I mean, the CV beneficial data at least. And when you have the oral semaglutide, if money is not the problem, where they will be used? I mean, where the place for DPP4 inhibitor? What do you think? Maybe down the line, 2 years, 3 years.
Hey, Banshee. I mean, I think that I'm going to be cynical, I guess. DPP4 are right now, they're a very expensive medication for what they give you. They have no cardiovascular protection, no renal protection, and a minor reduction of A1C. and it costs in the United States $300 a month. So sitagliptin is going to become generic in the next few months. So that may help. So I don't use DPP-4 too much now in my practice. Maybe the group that I use is in the elderly because it has very little side effects with mild control. And the other thing that we use it is in patients with type 2 in the ambulatory setting is in those who have kidney dysfunction, in the way that although you have to adjust medication according to which one of the DPP-4 you use, it can be used all the way in dialysis, and it has very little side effects. So otherwise, the utilization of DPP-4 is coming down, at least in the United States, from about 20% to about 10% of the patients. It may change now that sitagliptin will become generic. But so far, it is for what they do for you compared to the cost benefit. I'm pulling away from using DPP-4 a lot now.
So if that's the case, what is your opinion about the combination of DPP-4 SGLT2 inhibitors that we've got? I mean, does it make a good combination?
When it becomes generic, I'll use it. But I think that if I have to
And
use
in India, it is
combination,
already in generic form.
I'll use metformin, SGLT2. I love that combination.
People argue the fact that the benefits are driven by SGLT2 and not by DPP-4. So do you think there is a role of DPP-4 in the combination?
There are two different mechanisms of action. I'm sure it's very effective. I mean, I think that the goal in diabetes care is to combine agents with different mechanisms of action. That's right. So, but if I'm going to use a DPP-4 because of the incretin effect, I would use a GLP-1 for sure, because it's more potent and it has cardiovascular protection, renal protection, which DPP-4 don't have. So, and that's why, I mean, DPP-4 are okay. But if I'm going to use it because of the incretin effects, if I could use GLP-1, hands down, I would use a GLP-1.
Dr. Cyrus, a question to you. How much do you really think triglycerides should be aggressively pursued? And at what level do you think that you should bring it down to? And what should be a starting point? Because that's, you know, in our population of people, we do come across very high triglyceride values. So as a cardiovascular risk, where would you put triglyceride lowering?
Okay, so I think that there are two parts to the question. One is, if you have triglycerides that are greater than 800, that's a whole different issue and has no, I would focus on the pancreatitis risk. So it has to be treated for reasons other than cardiovascular risk. And therefore, the recommendation is to treat that aggressively to reduce any pancreatitis. Now, if you take patients with a cardiovascular risk, that they have multiple cardiovascular risks other than diabetes, on top of diabetes, then actually the data does show that in terms of omega-3, well, to be specific, EPA itself, if used, can reduce the risk of cardiovascular events and diabetes further than if you just used a statin. Now, fibrates don't seem to have that same effect. So I would be very specific on what you used to lower the triglyceride level. So at this point in time, the recommendation is to use not just any omega-3, not fish oils, because there are many trials that show that some fish oils do not work. Okay? It has to be EPA that actually has the evidence for cardiovascular risk reduction. So that's what I would go with, between about 135 and 500. And if you had a high risk of cardiovascular disease. So that's what I would do. And that's what the recommendation is.
Yeah, Rajiv, go ahead.
Dr. D'Souza, for you, you know the Indian phenotype much better than most people. The Indians being the second highest migrant population in the US, and still not represented in the ASCVD risk scoring. Is there any risk scoring that is developed out of an epidemiological study and we can use it? Because we see premature heart disease maybe 1.5 decades earlier. So and we are not able to primarily prevent heart disease in India in spite of so many things. So is there something that we can do actually?
So you're right. I mean, the ASCVD risk score is fraught with, I won't go into them. There are a lot of controversies. There are problems with, socioeconomic status, which you didn't mention. So people with higher socioeconomic status have a different ASCVD score than lower, even with all the other variables equal. There is problems with that scoring system, and therefore it is just an approximation. So if you want to, use that in combination with perhaps levels, that might give you a better guidance. So in diabetes, for example, I realize in Asians, especially South Asians, the cardiovascular risk is higher in patients with diabetes and occurs at a younger age. And the BMI criteria also not the same. I mean, people with South Asians have more intra-abdominal fat than, say, Caucasians. And that causes all the metabolic differences. So I usually go by the actual levels, the LDL level, the triglyceride level. I think those absolutes are probably going to be better for the South Asian population than the ASCVD score, because there are trials that include that population for cardiovascular risk reduction in terms of the LDL number, but not in that ASCVD score. So I would go by the triglyceride level, by the LDL levels, the actual levels, and assess risk in that manner. Unfortunately, there is no tool that asked me that specifically would just help you with South Asians specifically, or any specific trials that looked at that. So we have to do the best we can.
So Dr. There's a question from Dr. Neeta Deshpande. Is the Q-risk score better for Indians? There's one validation in Indians by our counterparts from East India about Q-risk score in East India by Dr. Binayak and Dr. Samit. So do you think the Q-risk is a better score for us to use? Is what Dr. Neeta is asking.
Well, so I think you could use it, but I'm not sure that it has been validated enough in larger populations. India is not homogeneous. There is a difference in, say, South Indian people and North Indian and such. So, and there are different ethnicities. So I would say it's probably a good tool. I wouldn't say it's bad, but I also say that it may not be validated for all the different racial differences that we see within India. So I think that would be the next step. And then I would be more comfortable with it.
Cyrus, your comment on JBS score, Joint British Society score. So we have tried, the Q-risk, ASCVD and JBS score in our ICU patients who are getting admitted for 2 years. And we found that JBS and Q-risk are better for India compared to ASCVD. But your comments for that. We don't have any validation, as you are rightly saying. We don't have the last data, but still we want your comment on that.
I actually think the JBS score is actually pretty good, in my opinion, for South Asians. I feel it's better validated than the Q score. So if you want to use that, I would say that that's probably something I would depend more on.
Only problem is, Cyrus, it is costing, the app of JBS.
I know. Yes. So it is. But, so the institution can, I suppose, but like in our place, the institution pays for that. And so, the providers in the institution get to use it free. But I suppose maybe it could be part of a benefit of a society, like if you belong to Indian Diabetes, Association or something. It could be that the association buys some sort of institutional app, and that can be shared with people. I mean, that's an idea, but you're right. It's it is cost.
There is a question by Dr. Guillermo, and he asks you that should you place all diabetics on statins, and should we follow lipid levels once starting statins?
Yeah, so controversial and a very good question. So, we always did follow levels till 2012. That was the only way we actually followed whether we had reached goal. And then the AHA came out with this whole ASCVD score and said, forget all about the levels, which, diabetologists and endocrinologists were shocked with that statement. But so the thing is, I would say that, we do the first part of the question, do all diabetes patients need to be on statin? Again, I would differentiate type 1. First of all type 1s can't be on statin. Many of them are under 18 years of age. So they are contraindicated in those patients. But even young type 1s who develop diabetes in their 20s, they don't necessarily have to be on a statin initially. I think it's a clinical judgment when you start it. Do you have albuminuria, for example? Have you developed any complication? How high is your LDL? Is it 100 versus 190? So those, I think, for type 1s is a clinical decision initially. Type 2, I feel it's a little clearer, and especially for patients over 40 years of age, that universally statins are usually beneficial for type 2 patients. And I would start it for sure in those type of patients. In terms of monitoring levels, I am all for it. How do you know the patient is taking the medication if you do not monitor the levels, right? So for compliance's sake, you must monitor the levels. And secondly, all the studies have been done with lowering of the level, 50% lowering or a certain target like below 70 or below 50 nowadays. In fact, the latest recommendation from the European Society that should be below 50, in fact, LDL. So all our studies look at the levels. So I always like to say concentrate on the levels rather than the ASCVD score.
I just want to ask Cyrus one thing regarding the lipid levels, whether we should chase more with the numbers or whether we should more with the percentage. Suppose you have a patient with 110, I want to reduce because it's a high risk patient to more than 50% of that to be reduced. So from 110, I would like to have more than 50% from the baseline. So it should be less than 55. I should chase that, or should I chase the total less than 50? I have to have a target for this patient, or less than 70 is the target. Well, most of the labs, they put the reports like this way, that this is the normal, this is the target, this is like, there is nothing like a target. It should be from baseline 30% or from baseline 50%. Now, different patients may have baseline different. One patient to whom you have started with LDL of 135 and you want for that particular patient 62.5, maybe the baseline 50% reduction will be there. With other patient, it will be 55 or 54, maybe the target for that particular patient. And the new targets, which is recently Lipid Association of India, we were talking that HDL and LDL should be the same, or rather we can go up to the LDL up to 30 milligram. I mean, that is what, below 55, definitely for high risk patient, but can we go up to 30? So just for a clarification, I want that.
So I think there are two sets of types of trials, one that look at the percentage reduction and one that look at the absolute level. But certainly, I recommend the 50% reduction. That is the primary aim. So even if you're like 120, so I would focus on the 50% first. Because, if you're 100, the 50% is 50, but that's what you should do. But secondly, if your initial level is higher, and after 50% reduction, it's still not as low as it should be, then you look at whether you should go lower. So as you said, over time, there has been a lowering of what that LDL level should look like. And it's almost coming to as though your HDL and LDL should be the same, but not quite there with all the societies. I have to say that not all societies agree with that. Currently, the most aggressive would be the European Society, which recommends, below 50. And recently, the American AHA has also agreed with that. So people with diabetes and cardiovascular risk events should be below 50. So to your point, I would first definitely use the percentage. And then if after the percentage has been achieved, if you do not have, look at your patient, if they have higher risk than normal, then I would go for the target of below 50. And, it's not unreasonable to say that eventually we might land up with an LDL and an HDL the same value. Because if you look at the natural experiment that exists, you have these people with certain defects in their, which prevent them from manufacturing LDL. Their LDL is like 8 and 10. They have no problems. They actually live to 100. They have no cardiovascular disease. So going down to even 0, theoretically, looks like it's safe. So, but the only problem is, can we do it? There are all these side effects that medications have. I mean, a lot of my patients cannot maximally tolerate. Then you have to add Ziria, you have to add this, you have to add that, PCSK9. What are the interactions? How much side effects can the patient tolerate? That is where the problem lies, not the threshold. I feel the threshold could be as low as possible, but can we really practically achieve that threshold?
Yeah, Rajiv, you want to ask? Nita, do we have time for 1 or 2 questions, or are we done on time?
No, we have time. We have time.
All right. So Rajiv, your question, then I'll follow it up for a question with Guillermo.
So Cyrus, it just got interesting with the levels. So I remember reading an article a decade back, which said that you are born with an LDL cholesterol of 30, and there's no documentation of coronary artery disease below the age of 1 year. So you get you start choking your coronaries beyond 1 year of age. So majority of Indians, at least, are breastfed till almost 9-10 months. It's only when you get top feeds that your coronaries start choking. So LDL below 30, would it be practical? Like, you go back to infancy?
That's what I was trying to argue, that theoretically, I don't have a problem going down to below 30. Okay, I don't think there's any safety issues. The problem is, how do you get there? I mean, when you try with a patient with diabetes, they already have a lot of medications, right, for all their different cardiovascular risks, and then you add medication after medication after medication. There is all these interactions, and the problem is the practicality. I don't know whether we can get people below 30. I mean, I don't know. I frankly think that compliance will be a huge issue, and that is where we will be, have a big problem.
Guillermo, question for you.
Sanjay, can I ask one question?
Yeah, please, sir. Go ahead.
Cyrus, I think it was a very good eye-opener to all of us, because there are 2 issues. I think I don't know whether probably it was not in this subject. First of all, standalone, what is the position of triglycerides? Because in our subjects, elevated triglycerides without abnormal cholesterol level is also a single most risk factor, particularly in diabetic females. Second thing, I personally feel that the cholesterol thing started from 1962, where Ansel Keys started cholesterol as a bad word in medicine. Before that, we never knew the coronary artery disease. Now, you see, after chasing cholesterol so badly, has the coronary artery disease reduced? No, sir. there is not a single bed available in the ICCU. In spite of lowering cholesterol and trying to get HDL cholesterol as high as possible, the main culprit appears to be oxygen-free radicals. And oxygen-free radicals come from probably high level of omega-6 fatty acids. If you don't reduce your content of omega-6 fatty acid, as much as you reduce your cholesterol, it is not going to give any benefits. This is our experience. And therefore, we chase both triglycerides and try to increase HDL cholesterol. At the same time, we also try to minimize the oxygen-free radicals. That is a more comprehensive approach that we need to take in our diabetic patients of South Asian origin. I don't know what is your take on that.
So, I think not only South Asia, but we know that there's a lot of residual risk, as we call it. So, in spite of statins and all that, there is a huge residual risk. Obviously, others we would have eliminated cardiovascular disease, right? And especially, I think triglycerides do play a higher risk role in South Asians. You're right about that. I feel that they have a higher risk component than, say, the Caucasian or African American population. But when unfortunately there is no real studies about standalone. Everything is on top of a statin. So we don't have something to show that, okay, in people with, say, statin LDLs that are moderate, if you just, and they have high triglycerides, if you were just to give, say, omega-3 fatty acid like EPA, would that, when compared to maybe just a statin, what is the difference, in cardiovascular risk reduction? It would be an interesting trial, but because of all the guidelines, I think it's ethically impossible at this point in time. But I think I agree with you in the fact that, in some populations, lowering of triglyceride is really important, especially the South Asian. Second part of your question is the oxidative stress and the radicals generated thereof. And we all know that this is a really important part. But, there have been smaller trials giving people things that try to reduce oxidative stress. None of them seem to have worked. Now, in your mention of omega-6 versus omega-3, the ratio of those three fatty acids, I think is important. Because I think some of the trials do tell us that, because if you recall a recent trial called the Strength trial, they used DHA and combination with EPA, and they in diabetes patients, and they did not have any success at all. So I think that's because of the use of DHA, perhaps, and perhaps the risk of cardiovascular risk in that population they selected was not that high in terms of triglycerides. But what I feel is, like, if you use the correct omega-3 fatty acid and change the ratio of the omega-3 to the omega-6, you probably will get benefits in that area. Again, you have these are research areas, so I wouldn't say that they are absolutes, but they are my opinions.
I'll
Thank
take
you.
the last question before we wind up, because we're running out of time, and this is to Guillermo. What is your take on using GLP-1s in lean diabetics? So what do you think should be the case?
Yeah, I mean, I use it all the time, and weight or BMI is not a criteria to utilize these medicines, and the weight loss that you see in a lean person is not going to be the same as an obese person. That's right. So the efficacy in reducing body weight, of course, is different, but the cardiovascular protection and renal protection is independent of BMI. So I have no problem with that. So, and this may be the final plea to, I don't know how you guys doing with respect to utilization of SGLT2s and GLP-1. We have a campaign at Emory University that will have 58,000 patients with diabetes. And the utilization of these agents is 1/3 what is sulfonylureas right now. And we're trying to look for avenues to educate our doctors. And I think this is, I'm pretty sure that it's the same all over the world, that these agents are not utilized, especially in those patients who really benefit. That's right. Those patients with cardiovascular disease, heart failure, they should be treated with the new agents. So we have a big task and in front of us, and how we educate our primary care in utilization of these agents in this patient population.
Thank you very much. A big round of applause to our speakers. I think they've done a marvelous job. Very well, the lectures have been very informative. And I'd like to thank both of you for this lovely interactions that we had in the last